The last part of our conference is going to be on the Choosing Wisely movement that has been part of the ABIM Foundation. And Dr. Knupp was so kind as to start talking about those topics. And basically, what is the Choosing Wisely? Choosing Wisely is a national medical stewardship campaign led by the American Board of Internal Medicine Foundation in collaboration with specialty societies. And basically, it's challenging the specialty societies to develop 5 tests, treatments, or procedures that physicians and patients should question. The ABIM Foundation recommends that societies consider evidence-based medicine, cost, frequency, and clinical purview in making their recommendations. American Society of Hematology identified 5 topics initially with a guiding principle to avoid harm to patients. In the interest of time, I'm just going to go through the first 5 topics that were utilized as the Choosing Wisely campaign from ASH from 2013. And I'm going to go through these, and then we're going to ask our panel to come up, and anyone of the audience that has questions or patients that they want to talk to the panel about related to the guidelines or independent questions would be welcome. The first one is don't transfuse more than the minimum number of red cell transfusion units necessary to relieve symptoms of anemia or to return a patient to a safe hemoglobin range, 7 to 8 grams per deciliter in stable non-cardiac inpatients. Number 2 is don't use testing for thrombophilia in adult patients with VTE occurring in the setting of a major transient risk factor such as surgery, trauma, or prolonged immobility. And Dr. Knupp clearly discussed that. Don't use inferior vena cava filters routinely in patients with acute venous thromboembolism. And don't administer plasma or prothrombin complex concentrates for non-emergent reversal of vitamin K antagonists outside the setting of a major bleeding, intracranial hemorrhage, or anticipated emergency surgery. Limit surveillance of computed tomography scans in asymptomatic patients following curative intent treatment for aggressive lymphoma. Now, these were the first 5 that were brought up in 2013, and one thing I failed to mention is what they're looking at, and you can get more information. In the interest of time, I'm not going to go through these in any detail. As you can see, these slides had additional detail, but you can actually go on the Choose Wisely for the American Society of Hematology and get all of these slides. Now, last year, they came up with a second set of Choose Wisely initiatives. Number 1 is don't treat with an anticoagulant for more than 3 months in a patient with a first VTE occurring in the setting of a major transient risk factor, which Dr. Knupp discussed today. Number 2, or this would be number 7, would be don't routinely transfuse patients with sickle cell disease for chronic anemia or uncomplicated pain crisis without an appropriate clinical indication. Number 8 was don't perform baseline or routine surveillance computed tomography scans in patients with asymptomatic early stage chronic lymphocytic leukemia. 9 was don't test or treat for suspected heparin-induced thrombocytopenia in patients with a low pretest probability for HIT. And finally, don't treat patients with immune thrombocytopenia purpura in the absence of bleeding or a very low platelet count. So I'll ask our panelists to come up and have a seat, and we'll open the floor to any questions the audience may have. If there are no questions for the panel, I do have a case presentation that I can do.
Dr. Butler, I think we are going to have a question back here. So let me know when you want to take that.
The number 1 point about the excessive transfusion of red cells, would a similar point apply to use of erythropoietin?
You meant EPO, erythropoietin?
Yes,
yeah, those guidelines are really become quite strict. At one time, EPO is one of the greatest used drugs for Medicare, and they cut back on that because of the increased risk of thrombosis. Where's my colleague over here? He's going to tell us all the things you have to worry about for cancer patients. They had all these randomized trials of EPO versus no EPO, and thinking that if you had high hematocrit, you feel better. But all of them showed decreased survival in the patients who got EPO and had cancer. So there's concern, although the pharmaceutical industry says there's no proof, that there are EPO receptors on cancer patients. But I turn to my spotting colleague for these real questions.
I would agree with you. I think that the guidelines have gotten stricter based on this. I think there are EPO receptors on cancer cells as well as blood vessels and other places as well. And so currently the recommendation is not to give it unless the hemoglobin is below 10. And then again, I think there are many patients who really tolerate much lower levels. And so again, part of the art of medicine is defining when you need to use a medicine and when you don't. And so again, I don't routinely give erythropoietin or transfuse people unless I feel they're symptomatic related to the anemia. They can be tired because of their cancer or because of their chemotherapy, because they're malnourished. That doesn't mean you necessarily need to use a hemoglobin trigger to again start EPO or transfusing.
So I'll present the other side of the coin there, and that is, let's think about also the chronic anemias that we see due to hematologic malignancy, specifically the most common being myelodysplastic syndrome. When those studies that Dr. Ware was talking about became known, head and neck cancer patients, lung cancer patients, breast cancer patients, where the purpose was to drive the hemoglobin to higher levels to improve quality of life. Some of those were being done, by the way, without chemotherapy. And they showed a worse survival. That's what triggered a moratorium on giving erythropoietin to all cancer patients, and myelodysplastic syndrome by WHO criteria is now considered a neoplasm, probably as it should be, but it's lumped together. And what is the data that erythropoietin actually impairs survival in patients with myelodysplastic syndrome? And there's absolutely none there. Now, most of it is retrospective, comparing patients who received erythropoietin with or without G-CSF to transfusion support in different countries, for example, showing no difference in rate of leukemic transformation, and in fact, actually an improved survival in the Nordic countries where they gave erythropoietin and G-CSF compared to Pavia, Italy, where they gave transfusions. Again, but that's retrospective analysis. There was one prospective study. You can argue that it might not have been powered to really see a difference, but it was done by ECOG, looking at supportive care versus erythropoietin plus or minus G-CSF, and they had an algorithm for starting EPO, then going up on the dose, then adding G based on the patient response. And they showed no difference in this small study for a worse survival. So what I typically do with my patients with chronic anemias due to bone marrow failure syndromes is focus on their quality of life and their functional status, asking if there are things that they used to be able to do 3 months ago that they can't do. And then if there's a question about whether their quality of life can be improved by raising the hemoglobin, a simple thing that you might try before embarking on a costly prescription for erythropoietin and waiting for a result is to give them a transfusion. Let's say their hemoglobin is down to 7, and will you really make them feel better by getting them up to 8, or is it all their comorbidities that are limiting them? You could give them a transfusion at that point, and if they benefited from it, then I think it's reasonable to consider giving erythropoietin plus or minus G-CSF and MDS for symptomatic anemia.
Dr. Asher, MCI, radiation oncology. It's traditionally been appropriate for solid tumors, in any case, that had hemoglobins of less than 10 to transfuse them because of the relative radioresistance of anemia. Not sure how well documented that is, but currently we, of course, have many combined chemoradiotherapy patients, and they are hovering below 10, but on the tails of what you just discussed. In the case of lymphomas that would have, as a hematologic malignancy, that would have hemoglobins below 10, what would you recommend?
I still don't give EPO unless the patient's really feeling poorly and I can document that getting his hemoglobin up really makes him feel better. I might add in myeloma, there are data to suggest that the use of EPO has increased the incidence of thrombosis, particularly in those patients who get IMiDs. So I don't routinely use it, Procrit or RNS or any of these stimulants, short of the patient telling me that he really feels poorly. And there are quality of life issues, but in general, I don't use it, no.
What about transfusion, sir?
Well, as an alternative, I would give EPO as an alternative to transfusions. If after transfusing them has been advised, I can show that their quality of life is enhanced, then I will do it. And usually the only time this really comes to fore is when you're giving intensive chemotherapy.
If I can add to that, the other thing to keep in mind about these arbitrary thresholds is, I mean, I know we all do this, but always keep in mind where the patient is in their therapy. There's this one patient I can think of that illustrates this point. Stage 4 lymphoma a double hit lymphoma went through 6 cycles of dose-adjusted rituximab with EPOC chemotherapy, and each cycle just getting a little bit more anemic, a little bit more fatigue. But with the last cycle, he develops febrile neutropenia and he gets admitted, and his hemoglobin is 6.9. And the inpatient staff has their algorithm, and they're ready to give him his first transfusion that he's ever needed with this potentially curative therapy. And I made the argument, he's done with chemo, he's at the end of his cycle, his counts are going to come up, and suggested that we just check a retic count. And his retic count actually was like 7%. And he had over 100,000 per microliter of retics. And so you get a sense that he's going to recover. You can foresee the future, and you can hold off and just tell him to take it easy for another week at home and avoid a transfusion that way. And of course, always keep in mind that you want to check for the other hematinics that patients need to make red cells, especially in some of the solid tumor patients, whether they're iron deficient or have other vitamin deficiencies.
Yeah, as an extension of that, there is one exception where I tend to keep patients' hemoglobins and hematocrits higher, and that's if I worry about a potential for bleeding. I get a patient in who's been bleeding from some sort of lymphoma of the intestine or something of that order, then I'm inclined to go a little bit higher because I don't want to be caught behind the 8 ball, leaving the patient at 8 grams and all of a sudden finding them down at 4 grams. But with that rare exception, I tend to leave patients alone unless they really complain that they're really that fatigued.
Can I ask the panel a question? When I look at these guidelines, I consider them low-hanging fruit, and I wonder where we're going from there. I mean, I look at these 10 guidelines, and these have kind of been how we've been thinking for a while, but now they're actually put into practice. Do you think we're going to have lots of other easy examples of how to recommend therapies?
Well, as a user of Epic, I can tell you that these modules are going to be pop-ups for all of us. And we're going to have to find a way of explaining away the pop-up, or we're not going to be able to finish our work.
Very practical answer.
I will say one thing with regard to PET scans and CAT scans, they're still being done when they really shouldn't be done. They're enormously expensive, and they certainly create a lot of anxiety in the patients. If you've got a negative PET scan, you really don't need to follow these patients with serial PETs or CATs.
So I noticed the guidelines kind of hedged a bit and said definitely after 2 years. Do you do scans between 0 and 2 years?
I don't do them. If you have a negative PET scan in Hodgkin's disease, as I showed in my talk, after the first cycle, I don't bother. They're not going to be positive after 2. We actually reported that in the paper. And they're certainly not going to be positive after 6 because they've got chemosensitive disease. If the patient relapses, a third of the time the patient will pick it up himself or herself. A third of the time the physician will pick it up. And a third of the time the patient will pick up. A third of the time the PET scan or the CAT scan will pick it up. Well, if you think about it, that's only the relapse rate in these situations where you're negative, whether it's large cell or whether it's Hodgkin's disease, is 5% or 10%. With large cell lymphoma, it's higher, so let's say 15%. Well, 1/3 of the time, the PET scan will pick it up early, so maybe it's 5%. 5% of the time, it'll pick it up, maybe actually closer to 3%. There's not a whit of data to show that picking up this tumor a little bit earlier, a little bit later, is going to make an iota difference in the overall outcome. So there's no reason to do these serial scans, and most certainly not to do them in chronic lymphatic leukemia. There's nothing to be gained. The time that I was also in low-grade lymphoma, there's no reason to do frequent scans. If the patient's asymptomatic, leave them alone. The patient has symptoms, the LDH starts to go up, then you may want to do something. And in my hands, I find a PET scan much more useful than the CAT scan. The reason for it is I'm looking at those SUV scores. If a patient is CLL, you finally say, well, this guy may be a Richter's. You do a PET scan on him. You're looking for a high SUV score because most of the time CLL is 2, 3, or 1. So you have to have a specific indication. CLL, you're looking for transformation. You want to know where to biopsy. In follicular lymphoma, it's the same thing. If the patient comes in to you and says, I've got a bad pain in my side, well, of course you would do it. But if they're asymptomatic, you really don't need to. And these scans are being still used far more widely than they should be.
So I have if you allow me, I have a word or two to add about this. So just like Dr. Coleman mentioned, there was, not so long ago, there was a large publication in JCO from the Mayo Iowa Consortium following a large group of patients with large cell lymphoma who, in their hands, had CT scans periodically after definitive therapy. And if you take the patients who, first of all, the majority never relapse, 85%. The ones who do relapse, 2/3 come to the doctor between scans with symptoms. From the 1/3 that you pick up at the time of the consult, all but 1.6% had either 5-year physical exam or a high LDH. So you're only going to pick up 1.6% of all your population by the instrument of doing CT scans. And there's no data whatsoever that those patients, and actually there's data showing otherwise, that those patients actually do any better than the patients that present symptomatic. So I wrote a letter that JCO was generous enough to accept. It's going to be published Monday. And there's a second letter, there's another letter on the article, also calling for perhaps more restricted guidelines, because this is, I understand the intent of the Choose Wisely, which is at least put a break, and okay, let's do for 2 years. What I think the language should be very clearly, don't do at all. And I think the problem with anemia and the problem with CT scans is in the same nature, somewhat by a perverted way, in a way that we practice medicine, where we tend to do things in absence of proof. The burden of proof was reversed. And now we have to prove that we can stop without harm, while it should be the other way around. We should have to prove that that intervention happened. And I went a little bit further in this, the other author that published a letter a couple of weeks ago had the same call, because those guidelines still make one exception, which are patients in clinical trials. And I understand that many of the outcomes are progression-free survival, but I don't think even then is justifiable because the rate of relapse is expected to be the same, and the majority of the relapse is going to be symptomatic nevertheless. So I don't see why there should be any different clinical trials. And what that does to the clinical trials is increase the budget tremendously, making clinical trials even less accessible to patients. Of course, I'm a little bit passionate about this.
I'll change the conversation from lymphoma and just to respond to your original comment. I personally appreciate the guidance on benign hematology because I think as far as the way we all are trained in this country, benign hematology seems to be kind of hit or miss. And there are not a lot of, randomized controlled trials and data that you can go to if you didn't receive the training in your fellowship. It's difficult to know where to go to for these answers. So it's not infrequent that I get a patient referred to me for transplant and they have an indwelling IBC filter and it's been in for 6 months and it's not retrievable. And now this is a 30-year-old male and he has to live the rest of his life with a filter. And so to get these guidelines out there just so, everyone knows not to do that, I think is important because I think our training is kind of limited in this area. So patients that are within 6 weeks of transplant and post-transplant. Now, as far as how long do we do this after autologous transplant or how long do we do this after allogeneic stem cell transplant, we do it indefinitely. I'm sure there's some guideline on when you can stop that, but I actually don't know when that is. So after transplant, we have the patient get a bracelet and they continue to wear it and they continue to have irradiated products. Now, the majority of patients that we see are myeloma patients, and so, frequently they may need additional therapy and they may need another transplant. So if they get out 5 years after their autologous transplant and they haven't had a second transplant, I'm not going to tell them, oh, you don't need irradiated blood products anymore. I continue to support it because there may be another transplant in their future.
So if I could, and I could add to that outside of transplant. So for our internal medicine colleagues in the room, what we're talking about is irradiating a unit of a cellular therapy, red cells or platelets. And the only reason for doing that is to prevent an incredibly rare complication of transfusion-related graft versus host disease, which is almost uniformly fatal, causing marrow-aplasia, rashes, GI, and hepatic toxicity. So that's what you're trying to prevent. In immunosuppressed patients, what you're worried about is engraftment of whatever donor lymphocytes are there in the transfused product. So patients who are getting immunosuppressive therapy, I think you should consider it. I know we saw a case when I was at the Farber of a patient just getting therapy for Hodgkin's disease who had an autologous transplant who developed it. So it does happen, it's rare. Outside of the transplant community, where you really want to be careful is when you are thinking about family member directed donations, especially in highly advanced communities that might have a limited number of HLA types. So a great example of that is in Japan, where family members will donate for some other family member, and those units are irradiated to prevent transfusion-associated graft versus host disease because of sharing of haplotypes in a direction that allows them to engraft, but then causes a graft versus host disease. But outside of transfusion, I also would include patients who are getting immunosuppressive therapies as well.
I think this is a big problem. I think this is a big problem because there's no consistency here on the panel, there's no consistency in the community, and what you're hearing is you do it around people who are transplanted. Well, a lot of the early reports were people who are just heavily immune suppressed, either Hodgkin patients, CLF, but it almost never happens. So the big question is, how many people, how many units should everybody be irradiated to prevent something that's extremely rare? So I'd say this is one of those choosing wisely things that needs to come out with a very firm policy, because it is all over the map.
So not quite as low-hanging as the other fruit. And I agree
Well,
with
it
you.
should be low-hanging, and we should have a policy that says this is the way you do it.
But that's driven, hopefully driven by some data, though, right? Yeah. And I think that's the difficult part.
In point of fact, all the lymphoma patients are getting Rituxan, B-cell lymphomas. And we don't irradiate the cells on a routine basis. And all of them are immunosuppressed. It may have something to do with T-cell suppression rather than B-cell suppression. But if you put patients on Rituxan, particularly if you put them on maintenance, they all will become hypogamma, at least of one form or another, IgA, IgG, IgM. You can just look and see. But I really don't run into that, and I use a lot of Rituxan. So I guess we need to be very specific. I think it has to do with the type of immunosuppression you have. And I'm inclined to think that T cells are probably more important in the situation than the B cells.
Did you get your question answered? I don't think so.
Did we miss your question?
No, you did a good job. Thank you.
Are there any other questions? Dr. Butler, do you want to do one of your cases? I don't know if we'll have time for Rick, but your thoughts? Well, yeah, we don't have long. Everybody's going to go, oh, it's beautiful.
Since we have plenty of lymphoid malignancy experts, I'll present this one here. This is a 45-year-old African-American female with a history of lupus erythematosus. And I present this case because this is something that is not uncommon to hematology practice, where a patient is found in the setting of a peripheral neuropathy to have an elevated IgG level and elevated gamma-globulin. Basically, this patient is 42 years old. She does have a peripheral neuropathy that's axonal type and has actually become quite debilitated from the peripheral neuropathy. So after seeing her rheumatologist, thinking this may be a vasculitic syndrome causing this, they found the paraprotein and said, we want to know, would you treat her for multiple myeloma? And so in the interest of time, basically, she was found by neurology consultation to have a bilateral sciatic polyneuropathy, axonal in type. It was initially considered related to vasculitis secondary to lupus. She had also developed painful neuropathy with abnormal gait and disability. On further examination, she had a skeletal survey with no lytic lesions, a bone marrow with 80% cellularity, 13% plasma cells, with rare atypical types, occasional large forms, and a rare binucleate form. Increased stainable iron, flow cytometry showing 2% plasma cells, but there was some abnormal Lambda restriction and abnormal CD56 expression. There was hyperdiploidy. 24-hour urine showed only 124 milligrams of protein for 24 hours and no monoclonal protein. And other workup is shown here on this slide where her free kappa light chain and free lambda were both elevated with the normal kappa lambda ratio. Her beta-2 microglobulin was at 4.4. It was repeated, by the way, with 1.7. Set rate was 116. So the question that's asked and the pressure from the neurologist who doesn't know what to do with this patient, is not responding to gabapentin or other medicinal therapies, would you treat her for multiple myeloma?
May I ask a couple of questions before I
I would look for Emily.
Well, then I think, and I'll ask because I know that's probably something that crossed the mind of many of us.
Did the patient have anemia or bone lesion?
No anemia, no CRAB criteria. Her calcium was 10.6, but I'll repeat, it was normal.
And was there any chromosomal abnormalities in the marrow?
Oh, no, there wasn't. Fish was normal, no 46 double X.
It was the merest thing for Congo red.
It was not.
No, I haven't got that far yet. On the, basically, she had a sural nerve biopsy that was performed, and it did not have a Congo red thing performed. But this is the findings. It was actually referred to UAB for an opinion from a pathologist, and basically these were the findings there. I won't read those to you, but it's was limited somewhat by artifact.
The big issue here is the neuropathy caused by the monoclonal IgG spike. I noticed that it was lambda, so that increases the possibility that this might be amyloid, but I'm not sure that amyloid would present this way neurologically. I'd be interested to know what her gamma-4 levels are, but notwithstanding that, it is extremely rare to see demyelinating diseases or nerve diseases from IgG. Almost invariably, they're IgM. They have been reported, but they're extremely rare. So my inclination is to think that lambda IgG spike is not related to her neuropathy, unless we can in some way or another prove that there's amyloid there. If you want to treat her on the basis of what her chromosomes are, what her fish shows, et cetera, but I don't think this is really the indication for it personally.
I would agree, and actually we commonly get referrals from rheumatology with patients who have an M spike. She does have, a significant or demonstrable amount of her actual monoclonal plasma cells in her bone marrow, so she should be watched. But I don't think she meets any criteria for systemic therapy.
I actually looked this up once, that I think the number of IgA and IgG monoclonal gammopathies associated with neuropathy, I think, are single digits, actually.
And you didn't mention these things, but I'll ask anyways. Did she have any adenopathy or organomegaly? Did she have any endocrinopathies associated with this? And was her skin normal? Those would be the other three things.
Yeah, saw no abnormalities in those areas.
Were you thinking of ones?
Yeah, Poem syndrome.
Yeah, it's very interesting. We described in the Annals of Internal Medicine when my colleague to the left was in swaddling cloth. The syndrome was cerebri. IgA more than IgG spikes associated in females only, peripheral neuropathy and Castleman's-like disease. But I don't think she quite fulfills those criteria here.
Good luck convincing the neurologist, by the way.
He's not happy with me.
The last point that we made perhaps is not the best case to simplify it because we have a pretty good size and spike here. But often you're going to see, particularly in young patients like this with a pre-existing autoimmune disorder, you're going to see a small monoclonal spike, which not necessarily means an underlying independent neoplastic process, but just polyclonal expansion of whatever B-cell processes drive that autoimmune disorder. So it's very often you see, if you go to my clinic like 3 or 4 times a week, you're going to see a 0.3, 0.4, 0.5 M spike in a set of autoimmune disorder that has nothing to do with it.
Has anyone ever tried taking these monoclonal gammopathies and using them to stain like a normal neuro tissue to see if there's any reactivity? Would that make any sense to do that? Has anyone looked?
Actually, I think it's been done. There's a fellow at our place who was very interested in this and did a lot of lab work into it. Almost invariably, IgM does it. IgG just doesn't do it very much. Many years ago, one of the people were searching for an antigen responsible for the production of monoclonal gammopathies. There was a guy by the name of Porter or Potter who was in St. Louis, this goes back decades, who tried his darndest to say that this is the reason they developed this monoclonal gammopathy, but it really hasn't panned out. And this really isn't what I would call classic gamma-4 disease, but I would check it anyhow.
Did you say what her race? Yeah, so she's African American, and so I just want to point out that she still does need to be watched, because certainly she can have more than one disease, although this happens in the setting of immunologic disorders, but still certainly we have seen patients that start to progress.
Just in follow-up, this is a patient that I saw in May of last year, and just to follow up, is we have followed her closely, and she has no signs of progression. In fact, her IgG levels diminishing, as is her free light chain levels.
So we're right up there.
He said we're right now.
Right. So we really appreciate all of you that survived till 3:45 here, and this is daylight savings time, so we do have more time out in the sun. So thank you so much, and please join us again next year.